So, very good evening, everyone. Myself, Tisho from Abbott Vascular. Today, in this auspicious program, Dr. Shuni Banerjee will be moderating the entire session. Sir is the needs no introduction. He is the HOD and he is the all in all of Kolkata Heart Lung Center. And our expert panelist, Dr. PK Hajra, is also with us. And sir is from as a HOD in AMRI group of hospital. So today, our first speaker will be Dr. Dhumle. So, sir, you can start. You can share your screen and you can start your presentation. Thank you.
Okay, just 1 second. I'll share my screen first. Is my screen visible?
Yes, sir. It's visible.
Yes, sir. Just a second. Saurav, just make it live in YouTube as well. From support, sir. I'm talking about the support.
It's already live on YouTube.
Okay. Please, sir, carry on, sir.
Good evening, respected chairperson, Dr. Hajra, sir, and respected moderator, Dr. Banerjee, sir. So it's my pleasure to present my first case as a consultant in front of the stalwarts of the field of cardiology. So I'll start with presenting a case in which it was an OCT-guided IVL-assisted PCI in a case of NSTEMI with calcified left anterior descending artery. Myself, Dr. Saurabh Dhumale. I've recently joined as a consultant at Artix, Calcutta. So to begin with the case. So my case was a 57-year-old male who was hypertensive, non-diabetic. He had a history of NSTEMI 2 weeks prior. He underwent a CAG outside at hospital in Patna, which showed double vessel coronary artery disease. They attempted a PTCA to LCX there, and they were unable to cross. So the relatives, they decided that they wanted to move to Calcutta. So the patient was brought to Artix. Now, probably they attempted LCX because the troponin was high over there, and the LCX was abruptly cut off without any collaterals from the other side. But probably the LCX was an old thrombotic occlusion, and which had turned into some kind of a CTO, because we got a MyView scan done, which showed that the LCX territory was non-viable and the patient's EF was 45%. So when we took him on table, this was his angiogram. So as you can see, the LCX is cut off from the proximal part, but the LAD had significant calcific disease and almost 70 to 80% stenosis in the mid part. But the patient had significant symptoms and has had one episode of heart failure. So we proceeded with the angioplasty. But as you can see, angiographic calcium is also visible there. So we felt that we would be met with few surprises while attempting to open it up. So we said, and the party agreed for imaging, and we might need some calcium modification after the imaging. That was the plan. So this is the first one.
We just wanted to have some discussion before you show this.
Yes.
First of all, can we have a right-sided image also?
So I didn't have it in the A, but right-sided coronary was the dominant artery, RCA, and it had no significant disease.
And there is no collateral to the LCX?
None, sir. None at all.
Okay. So what we found that there are two big diagonal arising from this calcific segment.
Yes, sir.
And before we take the OCT,
yes,
what do you think is the diameter of the vessel? I'm not saying that I am going to.
Sir, the vessel in the proximal part looks like 3.5 or 3.25 at max, maybe. Might look like a smallish vessel, but
maybe 3+ at least.
Yes, sir, 3+.
Yes, and distally, naturally, with the natural tapering, it will be difficult.
Yes, yes.
So, what you wanted to see in the OCT, the calcium?
Yes, sir. So we wanted to see whether this calcium, which is visible on the angiogram, so whether this calcium is actually a deep calcium or it is superficial calcium that might create some trouble. So based on what we saw on OCD, we planned what kind of calcium modification we might require. So we had told the relatives that.
No issue. Please go ahead.
Yes, sir.
Please go ahead.
So, yeah. So
Next
then,
image.
yes, sir. So this is the OCD run. So I'll gradually take it forward. I hope everyone can see. So this is this was our distal landing zone, which was not that diseased. But then as we came up, we could see a few lipidic plaques, then with increased signal hypoattenuation. Then there was some fibrosis here, as you can see. Then the branch comes off the diagonal. Diagonal didn't have a lot of disease, although it looked like that on the angiogram, but the osteum was relatively fine. Then here you can see a chunk of calcium at roughly around 9 o'clock to 12 o'clock position. Then here at around 4 o'clock, a nodule-like structure came up in between. Sorry. Let the OCD run on its own. So after this branch here around 4 o'clock, some nodule-like structure which came up during the year. So we were worried about that. And even while initially we gave the pre-dilatation with an NC balloon, and we found out to our surprise that that part was not really giving up. So segmental analysis of the OCT. So this is our distal landing zone. Then the proximal to the distal landing zone, there was this chunk of calcium, as you can see, but this was more of a deeper calcium. So we were not much worried about this part because we were sure that this would expand. But this was the part where it seems like it's indenting into the lumen. It seemed like a calcific nodule. So we prepped for that. And here, as you can see, another. This is not so deep, and there is a chunk of calcium another before proximal to that lesion. And in this very proximal part, you can see on the angiogram also there is some ulcerated plaque kind of relay. It looks like some kind of ulcerated plaque, but here we could see it was a healed dissection with some white thrombus along the way. So turns out the end-STEMI presentation and the raised tropi that he had probably was not from the LCX, which was occluded long back. Patient was having dynamic ischemia from the LED itself. So initially we took a 3x15 NC balloon, and we saw that in this particular part, the balloon won't expand. Then we decided that patient party was also willing, so we moved ahead with the IVL. After the initial NC balloon dilatation, there was some slow flow, which we managed with the usual cocktail, and the flow was normalized and there were no significant symptoms. Then here you can see that we proceeded with 3x12 IVL balloon. We gave all 80 pulses, first distally, then mainly at the site of the nodule, and then a little bit just proximal to the nodule. So as you can see, with the progressive sequential pulses, the 10-10-10 pulses, the balloon was opening up a bit more. So in the last one, the balloon has truly opened up a bit more. Now this is the post-OCT. So all through, we can see that we gained significant amount of lumen, and this particular part that will come now, where the suspected nodule was situated, had been cracked to some extent. This at your 3 o'clock, 4 o'clock positions, this part.
Now, where is the proximal landing zone you think we'll be having?
So proximal landing zone, sorry. I'll go back to the previous year. So we had a relatively healthy proximal landing zone. So this roughly around this area, we decided to land it, this area.
Fine.
Yeah.
And how much is the diameter here?
So it was more than 3.5, 3.75-ish.
Right.
So these are the things that we observed after the IVL. So this was the part of the nodule where we could see that there was some cracks which was imparted. And so we proceeded with because the distal vessel looked pretty thin. So we proceeded with a smaller stent of 3 by 38 diameter, also 3 mm diameter. And then we had the plan to post dilate it by 3.5 in the proximal segment and 3 in the distal segment. So the proximal part, we could expand with the 3.5 balloon. So this is the final OCT run. So pardon me for a poorer injection. So the dye clearance initially is not very good. So all through there is some whirling, but as you can see, the stent has very well expanded and well opposed. There was no proximal or distal edge dissections either. So this was the final angiographic result. This was the pre and this is the post. Thankfully, none of the diagonals, they went down. So patient was comfortable throughout the procedure. Patient had come to the follow-up in the OPD a week later and he was absolutely fine. So in conclusion, OCT can reveal multiple pathologies in an artery, not immediately appreciated by an angiography. So as we can see in this particular pre-OCT run, we could see lipidic plaque, fibrosis, then deep calcium, a nodule kind of structure. All those things were visible in this particular case. So appreciation of morphology assists in better bed preparation and eventually optimum stent expansion. IVL works in patients with calcium nodule as well. New data is coming up, as evident in our case too, while producing cracks on the either side of the summit of the nodule. So even the OCT company people, they also advise the same thing about people, that it is better to keep the IVL balloon on the side or the slope of the nodule if you're trying to crack the nodule, because you have to crack the base of the nodule. You can't really crack the peak of the nodule, so or the summit of the nodule. So it results in the collapse of the nodule as a whole if you're able to crack the base. Ideally, calcific lesions should be assessed by intravascular imaging, preferably OCT, because as we all know, OCT is better than IVUS in calcium identification and assessment. Although the SD IVUS is also good, but will still OCT wins any day. So if there are no contraindications from the renal side, definitely OCT should be the choice when proceeding with an calcific case. Thank you.
Great. Dr. Hajra, your expert opinion.
Yeah, nice case. There's a few observations. You have to tell me what was the SNH criteria. If you do not have circumflex, what is SNH criteria? You have two diagonals. You have not kept single wire.
So we've kept the diagonal in the. We've kept the wire in diagonal, sir. We had kept the diagonal. It was visible.
But in angiogram, there was no where I could see. As second, third point will be if you have done OCT in the LAD and it was without co-registration. So it's very difficult to identify exactly at what level the eruptive node. So tell me whether the nodule was eruptive or non-eruptive.
So it was sort of covered by lipid. That is, it didn't look like it was an eruptive nodule.
Yeah, it was a non-eruptive kind of nodule. You are right.
Yes, sir. Because the signal attenuation was a bit too much. So even
honest. Yeah, so difficult to crack, but the mass rate is definitely much lower than eruptive nodule.
Yes. Yes.
So if you do not have the co-registration, you have to. What type of IVL you have used? C2?
What type of, sir? Pardon?
IVL, balloon. C2 or normal balloon?
Normal balloon, sir.
This was 80 pulse, I think.
80 pulse.
So C2 would have been better for, if you see nodule, then be prepared with C2.
Okay.
Because you have more pulses and you have to spend the investment, you have to invest your energy. Co-registration is not available. So guess that is the approximate area. So come to and fro, like move
Yes.
forward, come
So
back.
that diagonal sort of worked as a guide
Yeah.
for,
Yeah.
we didn't have
You are
co-registration.
right. You are right. That
Diagonal
maybe
worked
the
as a guide.
diagonal was the lighthouse,
Yes.
but if you had the co-registration, then it would have made the life easier.
True, sir.
And then, if you see the diagonal, large diagonal, it is almost like a left-hand situation if you upload both the diagonals.
Yes, sir.
Circumference is gone. So imaging of the diagonal is also some people will do if there is a calcium, the IVL balloon in the IVL balloon in the LED would do some work on the diagonal branches also. So my question is, why didn't you think about bifurcation, dedicated bifurcation stenting?
Sir, we had thought about it, like we kept a wire in. If it had gone down, we probably would have done provisional stenting. That
Right.
was, yes.
So when you saw that the flow is good, both the
Yes.
vessels are flowing nicely,
Yes, sir.
and you made it like just one stream strategy, had it been a slow flow, no flow, or some kind of
We would have
jeopardized diagonal, would have put a tap stenting in the
fill
diagonal,
out something. Yes,
fill
sir.
out something. I'm very happy that you could show all the devils of OCT in detail, the
Thank you, sir.
calcium and the depth. You could recognize the non-eruptive nodule. You could.
Means a lot coming from you, sir.
No, it's okay. So these are really quite impressive how you present this type of cases in national and international. Congratulations.
Thank you.
Nothing else. Thank you.
Thank you. Great. So Uday will rise up with his excellent case, we hope. Uday will analyze your case first and then we go to the detail.
My slides is visible?
Yes, full screen came. Yeah.
Good evening, Sunil Banerjee sir and Dr. Hazra sir. My case is actually 53 diabetic, quite controlled. HbA1c was quite less than 7. He is non-smoker, non-hypertensive. He actually came to my clinic for fitness prior to going to trekking. Actually, he's going to Kedarnath. So, on query, he had a history of acute onset chest pain 6 months back. And that time he took some antacids and some syrups, all these things, and his pain got subsided. After that, he never consulted any cardiologist. This time having some sort of shortness of breath on walking upstairs, say up to 3rd floor, 4th floor, but not the first floor or even 2nd floor. His ECG shows loss of R wave, inverted in precordial, inverted in precordial leads, but still it is R wave is quite preserved. Although some of the leads shows R wave is absent, like in V1, V2, but V3 onwards R wave is preserved. Echo shows LV dysfunction with wall motion abnormality restricted to LED territory. So I advised him for dobutamine chase echo, which actually shows the biphasic response. So this patient might have get some sort of benefit if I do the some revascularization. So he was taken to the cath lab and diabetes was controlled, creatinine normal, hemoglobin normal. On the right shoot, which RCA was dominant without any disease. And LED is getting flow from RCA up to its almost mid part. And LED is cut off after the big diagonal. No antigrade flow. Most of the flow are coming from very faint antigrade flow is there still, but majority of the flow coming from the RCA through the septal branches. So different views showing the same. So I asked him already the dobutamine stents were done prior to the angio. So straight away wait for revascularization. So that is a CTO. LED CTO it first started with the microcatheter with the help of fielder FC, but it's not going into the true lumen. It's going into the septal branches. Tried, kept the microcatheter. I took the Gaia one first, but it is not in the right track. It's going away from the true lumen. Try to negotiate through the CTO segment into the true lumen, but it's not going. In fact, it is not getting close to the distal cap as well. So either in the false lumen or in the wall, or sometimes it's going into the septal branches. It's getting buckled, sometimes it's getting buckled, trying to move, trying to going through the with dot, it's not going. Change to Gaia 1 to Gaia 2, still it's going into the just before the say distal cap, going into the vessel wall, into the LED. Although the RAO crania is showing into the true lumen, but it's quite it's not in the true lumen, because in the LAO cranial is showing quite away from the true lumen. Somewhere in the mid part of the CTO segment is going into the vessel's wall and is going. So this type of I'm coming back again, going, trying, negotiating, and it took almost 2 hours, but still I'm not in the into the true lumen. So trying. So my plan was to.
Can we wait here just for
Yes,
a
sir.
while?
Yes.
So, see, radiation is an important issue. So you are taking so much time. So what guide catheter it is? Has it a long sheath along with
Yes.
guide?
No, sir, not long sheath. It's normal sheath, normal peripheral sheath, one right-sided radial axis for right shoot, and the femoral shoot, femoral axis, the normal 7 French, and it is a 7 French guide cath.
Fine.
TLS.
Okay.
What should be your first wear? Like if you have this kind of, what is the, if you are discussing CTO,
Yes, sir.
the dictum is first you tell me the patient profile, second you tell me the JCTO score or some kind of score.
Okay.
Third will be your strategy. Like if you tell us clearly, say, look, I will go by this algorithm, I will do this where, that where, then
Yes,
I'll, this fail, then we'll go to that where. So you
Yes,
did
sir.
not tell us the JCTO score. Tell me what is the JCTO score in this case?
Sir, it is totally flashed cutoff,
Yes.
and there is 2 branches, one in the septal, one in the lateral, and it is not tried earlier. It's free from calcium.
Tell
And
me the
the
CTO score. CTO score.
Sir, I'm telling all these points are in the CT score.
Yeah.
Sir, it is flashed card, it's never earlier, tried earlier, it's not a blunted, it's not a taper. When there is some branches are there, and the segment of the CTO segment, I think from right shoot, it is not beyond the 20 millimeter, and it is free from any calcium. So it's not a very high risk, it's not a very low risk, in between 2, it's coming around 2. So JCTO score is coming around 2, but it means it's not extremely difficult, but it's difficult, not in the very easy.
Right. So cap is ambiguous or non-ambiguous?
Yes, sir. Cap is slightly ambiguous.
Ambiguous. Second, length of the CTO?
Length of the string, I think it is less than 20 millimeter. Initially, I thought.
Okay. There is no calcium?
No calcium.
Okay. So there is no visible calcium on the
No
procedure.
visible calcium, say right.
And it was a straight segment.
Straight
No,
segment.
hardly any branches. Then what type of microcatheter you have used?
Micros are fine cross.
Fine cross. Okay. And then what type of wear you should like to use as a bailout strategy?
As
Like pure
bailout,
filter
sorry.
or what?
Sir, I
Yeah.
first started with fielder, sir. I started with fielder with the help of micro, because micro sometimes acts as a
micro
supporting
channel wear. So you thought there will be micro channel, your
Yeah,
1 0 less than 1 0 wear like fielder FCL work?
Yes, yes,
Okay.
sir.
Okay.
But it
Good.
was not going, so change to Gaia 1 and then to Gaia 2. But still
Right.
it's not going. So my plan is to now to change from single wire to parallel wire technique, because every time is the first wire going into the false movement. So I have taken the second wire and trying to negotiate to distal cap by seeing that RCA shoot. It's close to the distal cap, but it's not going into the true movement to the distal cap. So trying more. This is not in the true track still now. Now, here is the way, here is the step where actually I am going into the true movement. Now it's getting progressing. I can feel that in that time, that is now getting progressing. This is the step where I actually feel the distal cap getting ruptured, and I am into the true movement. So
you
this was the
started with fielder.
I started with fielder.
How
And ultimately I went into the
how did you remove the microcatheter? So what are the methods?
Sir, said that balloon I actually used into the guide Cath.
Okay.
I removed the micro catheter from
the trap balloon? Do you have the
trap
trap
balloon. Like I am
Do you
telling
have
that
trap
trap
balloon?
balloon technique.
No, you have the trap balloon, dedicated trap balloon. Nowadays, it is available in your lab.
Now said that that conventional and initial days were used. So
Okay.
the
Okay.
balloon
There-
beyond this micro.
Nowadays, a trap balloon available.
I use at 2.5 because the guide Cath is 7 French. 2.5.
No, actually, Uday, what Dr. Hajra is trying to emphasize that we all use this balloon trapping with a used Oxford balloon.
Yes, sir.
That's the conventional thing. But now there is a trapper has come, which has a very low profile. You need not put a wear, and it actually made your life easy. The chances of progression or losing the access is much less. Am I right, Dr. Hajra?
Yeah. Trapper balloon, yeah.
Sir, one more thing, over the wire balloon, we can use very small over the wire balloon.
Over the wire balloon availability is a question mark, and the length of the system is difficult. But anyway, it's a good thing. Maybe my take is that I would have taken the parallel wire a little bit earlier rather than.
Okay, that's
Anyway, that's part of you are the operator, but you are
now you are pushing the wire without checking where it has gone. It was a too rapid push of the wire. You must be thinking that it has gone into the vessel. It may not have gone inside the girth of the vessel. It may be just in the pericardium. So before pushing the wire so fast, like in your frame, as if it was like within a flash of a second, the wire has gone into the distality.
Yes, sir.
That should not be done. Slowly check, then go.
And yes, sir. And so retrograde should showing it is in the true lumen, the distal LED. Then started with dilating with very smaller balloon, 1.25 balloon. Then again this is the 2 balloon, 2 just compliant balloon, 10 millimeter up to 10 millimeters, so that to create the lumen. Then another run purpose wire actually passed, and this Gaia actually Gaia 3. Finally, the crossed wire was the Gaia 3. I removed this Gaia 3. Now again 2.5 millimeter. This is non-compliant balloon at high pressure. Checked it. Now I'm taking the stent actually.
No imaging.
No, sir. Actually, no imaging because of financial issue.
Okay.
Financial issue because
So
I told him this
in
is
presentation, you shall always mention that I would like to do imaging, but since there is
yes,
economic issue, I could not do it. But would have been better if I could have done the imaging. Okay.
But after stent deployment, it was the giants. But after the stent deployment, this was the picture of LED ostium as well as the LCX. Sir, already 3.5 hours over. Now I thought I'll just post dilate and will come out. Now after the stent deployment, this was the picture of LED ostium and that's having the chest pain. This time patient having the chest pain. Right. Although BP was holding. So I checked the ACT. Whether this long procedure, the ACT was quite good, 270. And he's a male patient, 53 years, quite healthy. Almost 8,000 heparin I gave him. Still 8,000, in fact 9,000. So ACT was normal, feels some radiolucency in the proximal segment, whether it is some dissection, because ECG also having some changes, as well as the dissection tag extended up to the L6 as well. This could be the possible. So very gentle contrast injection in multiple views also showing some radiolucency. Could have been the dye streaming in the L6, or it is just so the flap is extending from the left main to L6 as well as LED. So I did not took any risk. So this was the prior to the wiring. There is nothing was there. The similar type of injection with the big tiger catheter. This was the after stent deployment. So my gut feelings was I probably somehow that Gaia 2, Gaia 3 during negotiation assignments is introduced into the LCX. So straightway I took a first wire, passed into the L6 to OM, took another stent from L6 to OM, keeping the mind while going into the bifurcation of the left main with mini crush or decay crush. Basically, it was done by me. It's mini crush. So one 3.5 millimeter balloon I kept in LED, and this was also 3.5 millimeter stained as well, also giants. So I deployed after checking. The stain deployed and the stain proximal part in the left main, it was crushed by the 3.5 millimeter balloon at a high pressure. Again, I took the another small 4 millimeter balloon for crushing in the lip main. So finally, the 4.5 millimeter stain I took from left main ostium into the LED. And this time I took out this LCX wire actually. And the aleocranial view, the stain was deployed. Then I did the pot with 4.5 millimeter balloon with ostium up to the ostium. Now again, there is some problem. I just did this procedure by mini class, so I actually went through the stain start to the proximal stain to inspect. So it was not going through the proximal stain start. Every time is going into the through the distal stain start, and sometimes is going outside the stain start, in between the stain start and stain and the vessel wall. So what I did this time, I took the balloon in the LED, post dilated throughout the LED stent, and kept the LED wire, LED balloon just beyond this LCX ostium. Then I took the this was actually filter FC that I used on the first time. I took this filter FC wire and I went into the LCX through the proximal stain start. So as I am doing this class technique. So, and the LCX stain start is opened by 2 millimeter balloon that I used earlier. Somehow it is came out. Again, I did this procedure once more. And then post dilatation of the LCX was done with 3.75 millimeter balloon. And the kissing for both the LED and LCX was 3.75 and 3.75 as well, both vessels, almost similar diameter. And the final pot was done. And this was the final result of RO caudal as well as the distal cranial. And I thought this time again whether I have done something else with the distal LED stain. But after giving some GTM and in the closer view, it looks there is no ease. Some spasm was there. And this was the final.
Have you lost any proximal diagonal?
Yes, sir. One proximal diagonal.
Is it so? Was there any collateral frill? I think from the RCA also.
Some feeling, but one diagonal is there. Still, I lost one diagonal.
Now, at this point of time, do you want to further optimize the proximal mid LED area?
I didn't have any imaging, sir, but it looks.
No, the stent boost, it was looking okay.
That time I feel so, sir. But it not looks so much good now.
But anyway, the thing is, I think you have done a very commending job, saved the patient life. So we can have hours of discussions. So my friend and expert, Dr. Hajra, let's give you.
Yeah, it's very nicely done. I think my take will be one stent could have done your job after you saw that there is a progressive dissection of the left main ostium progressing towards the LED ostium progressing towards the bifurcation zone. That is number one. Number two, I think there is a gap between your left main LED stent and the first stent which you have put in the LED. Since you do not have any stent boost like imaging, I cannot tell you exactly. But when you are showing that aerocranial view, perhaps there is a gap in between. Anyway, so he's not going to come back with stent thrombosis right now, but maybe in the future it may come, may not come. And the technique which you have shown, balloon protection, balloon guarded entry into the side branch, is a good technique. Sometimes it works. Sometimes change of wear also, like if you have more steerable wear, if you have started with the run through, it is always one directional. But if you use the Sion kind of Asahi, where you have more torque control and you can shape the tip so that it can get steered into the area which you wanted to go. So maybe there are different strategies, but one strategy you should be very friendly with, that is knowing different types of wear rather than different types of gadgets, because you are inflating a stent in a situation where you already have some chest pain and compromise the balloon. You have to keep it inflated for prolonged period of time. But anyway, it worked. It worked maybe for a brief period of time. You kept the balloon open. And ultimate point will be, as Sunip has mentioned, you save the patient. And once the patient is saved, whatever you have done the best for that particular day.
Yeah, that's the big take-home message. Excellent. Even if you can use your micro catheter, that could have also allowed you to
Double one micro catheter.
proximal start. But anyway, the mini crash still, I think we are moving away from these issues. So what Dr. Hajra is trying to say, I also agree that if you can seal proximal LAD to left main, keeping a wear into the circumflex, and then you can do a tap also. But anyway, that's all a good take-home message. So patient has moved to visited Kedarnath.
No,
That's
not yet now. Not yet.
We'll go to Kedarnath, we'll bring prasad from you, and that will be the gift.
Yes,
Great case. So Dhananjay is the next speaker, I hope.
Yes, sir.
Dhananjay, please go ahead.
Good evening, sir. Good evening, Udaya.
Good evening.
Hello.
Dr. Kumar, can you share your screen, please?
Yes, sir. Yes, sir. I'm trying. So, is my screen is visible, sir?
Yeah, now
Just to change the mood of the this webinar, I'm presenting this complication in a BMB case. So, this was a young 28 years old male with severe MS. His MBA was around 0.7 centimeters square. We plan to do BMB, and everything was going fine. We putted LA wire after septal puncture, kept balloon there, but the LA wire was ox, and the balloon was also ox. So it catches the bend point was there in the LA wire, and it catches that bend point. And during manipulation, the bend extended further, and it took a bizarre shape. So finally, with rigorous push and pull, somehow the balloon came out, but the wire took a difficult shape to pull it out. I tried with a different type of catheter diagnostic as well as guide catheter, but by no means is why it was coming out. So I decided to took one
yeah, Dhananjay,
jugular access.
just a minute.
Sir.
We'll
Sir.
listen everything. You have the steps of septal dilatation.
Yes, sir. I have dilated septum.
You have that movie there.
Sir. I have dilated the septum. But that sequence, I have not kept that image, but I have dilated that. Sir. So after initially, I took a jugular access and tried with a snare, but sir, you know the hard nature of the LA wire. I was not able to pull the distal end of the LA wire through the snare. So then I took one pigtail catheter with J-tip metal wire inside that, and then I started pulling it from the one end and pulling it from the jugular as well as from the femoral side. So after about 3 hours of this uh, both sided pull, I was able to straighten this LA wire, and finally this came out. Finally, it, I was able to pull it out completely. After 3 days, I did his successful BMB. That's it from my side, sir.
Oh, it's a great save. It's a miracle. I never thought that the wire will come ultimately straight hand up. So what are the other options, or what are the other precautions we could have taken?
So the first is we should have wired the one kink LA wire. Later on I keep this in mind, and hopefully till now no such complication has occurred right till now. But that kink to we used to use that type of the kink LA wire because LA wire is not easily available thing, and you keep using the ox material for BMB because of the cost constraint and other things. But that kink, and particularly the kink in the LA wire and the ox nature of the balloon itself, both combined and causes that behavior. So that I thought was the major.
Yeah, even a little bit of kinking produces a friction with the stylus. It's a really difficult work. Do you think it was a high puncture, Dr. Hajra?
No, puncture is not the issue here. I think certainly, look, I am not the highest BMB operator in our country, but certain things my thoughts I can put in. Once you have this wire, you can always dilate, as Sunip was mentioning, with a larger dilatation catheter or even a small balloon. After you pass another wire, you have to pass another wire through your like a large like 7 French or 8 French sheath through that wire, cut sheath. Then once you pass the wire in the LA, you finish your BMB with the same thing, like you keep the wire there, finish your BMB the usual way. And once you finish your BMB, you enlarge that entry point with the septum, septal puncture. Once the hole is bigger, maybe it could have come out through the bigger hole. And that is number one. And number two, why did you wait for 3 days? You should have finished the same day. Maybe you got exhausted. Maybe you did not have another wire in your lab. That could be one of the reasons.
We don't have, sir. We didn't have that.
I understood. Another alternative could be you enter retrogradely, like you enter from aorta to LV, pass the wire, go through that MS, but it's very difficult in presence of mitral stenosis. Had it been like MR complication, would have been much easier to catch one end of the LA wire and you straighten it from one end and pull it from the femoral vein side. But since it was untreated mitral stenosis, it would have been much more very difficult. It is impossible, quite impossible to go through that mitral stenosis, but it is still possible. to go through, because you are entering from the LV side, the larger hole, larger chamber to a smaller chamber. It is difficult sometimes. But otherwise, that what you have shown here, that pulling by pigtail, or you have, these multi-loop snares. If you have a multi-loop snares, you could have done the same thing, like multi-loop snares from the internal jugular vein. You catch one end and pull from other end. That also works like a pigtail. But ultimately, what saves the life of the patient, that works best for the patient. Thank you.
And also, we are happy to see, Dhananjay, that you have the ideal quality of the interventional cardiologist, that is a perseverance. So that's the most important thing. So congrats and best wishes.
Yeah, congrats. Or if you could enter the LA, then maybe your snare could catch the other end of the wire. You can pull from the other end rather than pulling from the king end. That like
Sir,
you have.
I had used snare, even multi-pronged snare, but the tip of lever remains quite soft, but the shaft is too hard.
Yeah,
So
I
it
don't.
is difficult. Yes, sir. Yeah, it was
Could
difficult to pull the both.
Could you catch the soft end of the distal lever ever?
Sir, I have catch that one. I had catch that.
So if you pull that and if you bring it to the RA, then pull the whole assembly, I think it will come out.
Yeah.
No, sir. It has basically. I'm showing it again, sir. It has.
Okay.
Basically, the kink was such that the wire in yes.
Okay.
Kinked multiple times and
Sir, multiple times, sir.
multiple
And
areas.
yes, sir. Yes, sir. So it was not easy to put it through the air. This kink is.
Hmm.
So I was trying with a snare, but a snare was basically pulling whole the system up, and it was not relieving the kink from that point. That's why it was causing.
Okay.
not
A wire is also knotted inside. It looks like it's put inside.
Sir. That's why. The whole system was pulling upside when I was pulling through a snare.
Right.
Pigtail with metal wire helped me in resolving that the kink segment, so
Yeah.
that I was able to. Sir.
Right. Good job.
Good job. Great. Dhananjay, best wishes in future. And you saved the patient life. These are really patients who has crunch of funds. So young person should have a good quality of life in future. Thanks. So Navnil, you are waiting for your lecture ready?
My screen. So can you see my slides?
Yes, sir.
Yes, visible.
Okay. Good evening, sir. Suni Banerjee sir, MT Kajra sir, and my dear colleagues. This presentation actually, sir, I wanted to present for the annual ACI conference, where my topic was ACS in post CABG patients. But unfortunately, my next speaker had this same topic, that he has to speak on ISR in post CABG patients. So I could not present there. So I wanted to use this opportunity to present my case here. But this case was actually done during the COVID era. And this case describes a very unfortunate patient, as I would say, This is a 63-year-old gentleman, hypertensive for 15 years, who had undergone CABG in the USA in 2008, and where two grafts were put into place, the Lima to LAD, the SVT to RC. Unfortunately, he had to undergo reintervention twice, both in the SVT graft in 2015 as well as in 2018. So when he presented to us, he was complaining of chest intermittently associated with sweating for last 1 week, which increased over the last 1 day. However, when he arrived in the emergency, he was asymptomatic with stable hemodynamics. He also had a history of cough for the last 10 days. His troponin was positive, and this was his ECG. We can see there are Q waves in the lead 3 and AV in the inferior leads, and some ST depression in the lateral leads. So as I am reminding you, sir, it was during the COVID era. So to send an RT-PCR for COVID, and the working diagnosis we made was NSTEMI with probable COVID, and conservative management was started. But around 3 p.m., just after having lunch, he complained of severe chest pain associated with sweating. And in the meantime, his RT-PCR became positive. And ECG during that time showed rising ST elevation, thus resulting in an evolving STEMI. So he had two problems which we had to deal with, an evolving STEMI as well as a COVID infection. So immediately took him to the Cath lab with all the COVID protocols in place. And this is his left shoot, which shows some distal plaques in the left main. The L6 looks it was minor plaques. And the LAD is severely diseased and is completely cut off from the mid part. The right RCA is almost non-existent with some RV branch seen, is diffusely diseased. Sir, I do not have the Lima to LED shoot, but it was patent and flowing. But the culprit artery was this thing, the RSVG, which in spite of having two stents had developed another thrombotic lesion, not only in the proximal stent, but also in the distal part. Here is another view. So this was the culprit artery, and like a primary PCI, we had to open it. So a few words about the embolic protection devices. Because it was in the COVID era, which we know causes high thrombus burden, and these SVT grafts are also very friable and results in high incidences of slow flow or no reflow. So embolic protection devices we used here, and we have seen in the SAFER trial as well as in the FIRE and SPIDER trial, they have been shown to be of benefit. But recently I was going through some articles which showed that maybe due to the better quality of hardware and the better expertise of the operators, there has been not much appreciable differences in using as an EPD or not. So in both in ACC/AHA and the ESC, the level of recommendation has been downgraded to 2A. But in this case, we used it. We first used a Sion blue wire to cross the lesion, and then we took the SPIDER FX4, taking out the Sion blue wire and pushing the catheter into place. We had some trouble in negotiating the device to the proximal stent, but ultimately we pushed it inside and deployed it by pulling back the catheter. And the next part was done over that SPIDER wire only. We used a 315 NC balloon to predilate the distal lesion first and then the proximal lesion. Normally in SVG grafts, direct stenting is recommended, but since we had a EPD in place, we decided, and there was some difficulty in crossing the proximal lesion, we decided to predilate it for better delivery of the stent. This was the flow after predilatation, which shows some improvement. Then used a 4x30 resolute onyx stent for the distal lesion. And then a 4x22 onyx stent in the proximal lesion. It was well it was well expanded. And the flow post stenting was quite good. We then removed the spider device by pulling it into the catheter and removing the whole assembly. And this was the final result which we achieved. This is, and the patient was asymptomatic, and his ECG just after the procedure was showed resolution of the SVT chain. And so this
Patient
was
will go.
yes, sir. And the patient has not returned to us till now, so that's a positive sign. But we know that a repeat SVG stenting is most probable it will come in the future.
So have you something plan in your mind to open the native RCA CTO?
So the RCA looks very diffuse, so that will be our last option.
So it was a long CTO from the mid segment to distal.
It looked like that, long segment. We do not have any retrograde shoot, and we do not see any collateral.
Only one is that this sort of SVG, as you said, intervention, they come back and come back because whatever you do for them.
Yes, sir. You already came back. Yes,
Is
sir.
internet connection is problem or
Yes,
mine?
sir,
I
please
don't know.
repeat. No, sir, please repeat the question, sir.
I was just thinking that these sort of patients, they come back
Yes, sir.
repeatedly. Probably a ticagrelor for a long time.
Yes, sir.
Momentum.
GAPT for a long time
Yes.
with hydrostatins.
Yes. And any call from my expert?
Yeah, nicely done. How do you size the stent in venous graft? I mean, what type of stent, what size of stent you take in a unknown territory of sizing?
Usually, sir, the protocol says we have to take an oversized stent and not dilate very much.
Oversized or undersized? You take undersized stent. Usually post dilatation is not recommended, but how do you know that you have taken right size of the undersized stent? Anyway, so if you have facility for distal protection, I'm sure in future we'll have facility for imaging also. So that also helps. And going back to the Sunip's comment, doing RC is basically is very difficult. Though it is possible, we could not see any retrograde connections from the left system, or this graft can be taken as a conduit or retrograde wiring in the RCA.
Yes, sir.
After so many years of CABG, I'm sure that channel will be calcified. So
Yes,
we really want to contemplate next time. You should have CT scan, a good CT scan will delineate not only the origin is also anomalous here. So doing retrograde in anomalous RCA will be very difficult.
Yes,
because of reverse cut, whatever you do in retrograde anomalous artery is very difficult. So if it is anomalous, though people say always go for retrograde rather than antegrade. So I think your RCA was anomalous. Am I right?
We had to engage with an AR.
So it is post CABG, long years, anomalous RCA, going retrograde again will be very difficult. But as Sunip has mentioned that SBG graft, they come back with this stenosis. Maybe next time he'll do better with the drug-eluting balloon. in the venous graft, or you can take that venous conduit, as I mentioned, for retrograde entry into the right coronary. But you need a lot of expertise, a lot of gadgets, maybe a laser kind of thing in the future. A lot of expertise you need to open this kind of chronically occluded, very long segment, high JCTO score, post CAVG. Some people take one more score plus. So if it is normal JCTO 4 or 5, if it is post CAVG, it will be 6 because of long duration. So whatever you have done for the time being, I think long dual antiplatelet and praying to the God that he doesn't come back. If he comes back, give him the option of balloon, drug-eluted balloon. But nicely done.
Very nicely done. My observation is that you get this bad symptomatic patient when this graft get occluded in the circumflex or in the RCA territory. The same is not true for a instant restenosis masquerading into a stent thrombosis, except for the LAD. My observation was this in a couple of years. Probably they actually supply a lot of other territory, these grafts, not the PDA only. Maybe that will be the reason.
Can you show me the right coronary for a just for a brief of a second?
Yes, sir. Wait. Doesn't seem to be
Okay, it's all right.
opening.
It's all right. Do you have any other presentation today, Sunil?
I was just trying to check with Atanu. Atanu?
No, sir. I think all the presentation done, sir.
Yeah, all cases. Sunil, you conclude then.
Yeah, I think we had a very great opportunity to see this. I don't say senior or junior, the colleagues who are upcoming and who are going to take the next level of intervention cardiology. Big thank to you, particularly the planning, what you people are doing. That's the take home message in the future. Probably what Dr. Hajra was saying about the imaging, probably that's the future. I agree that cost is an issue, but maybe I am just thinking, or we all are thinking, that we need to have a system where all these patients should have an image guided, because these are not simple. The one which we are showing in the case, and then if it is image guided, we hope that this procedure should be the final for these patients, and a lot of planning becomes very important. So very, very well done. All the cases, we are very happy. We can congratulations to all of you. Thank you, Team Abbott, for organizing this.
Happy Puja from my side to all of you and your family. Very, very educative cases, thoughtful, quite insightful, lot of braveries and innovations and adaptations of newer thoughts. Imaging definitely will be kind of a spice to your curry in the future, and always try to think different from doing a routine thing again and again. So I'm quite impressed with your presentations.
Yeah.
God bless you.
So I take the opportunity also, along with Dr. Hajra, to give you your wishes from CSI West Bengal branch, and we are trying to do more from our platform also. Thank you. Thank you.
Thank you, sir. Thank you for this evening program, and wish you all a happy puja, Shubho Sharatya. Good night. Good night.